are going to talk today about a very fascinating topic of fat and bone and how these two interact with each other, and we now know that obesity is becoming an important epidemic and how it's going to change it. After that, we will be formally launching our course within our registered users, and this will be a long way in terms of improving management, and we have two cases on gynecomastia and pseudohypoparathyroidism which we'll discuss. So what we'll do is that we'll start with a very interesting concept of how bone and fat are interacting with each other. And this is basically largely driven from my presentation at the Indian Society of Pediatric Endocrinology. So those who have had seen this part, this will be a repetition, but then it was too fast there. So it will be much easier, I would say, to go from here. So we'll start off with this interesting concept of bone and fat. And this is relevant because obesity is really increasing a lot. So now we all know that obesity is something which is associated with a number of problems, including issues on diabetes, fatty liver, sleep apnea, brain, ovaries, hypertension, dyslipidemia, glomerulosclerosis. My task is to see whether we can add bone to that. And this is something which will have a huge implication on that. Now, we all know that obesity has increased a lot over the last couple of decades. There has been more than doubling of rates of obesity across the world. And what's very interesting to understand is that simultaneously there has been an increase in fracture rate. So we have seen that the fracture rates have doubled in the same period. So is there a link between increase in obesity and increase in fractures? It's something which is quite interesting, and this led to a lot of research which went into this area. And this is one of the more active areas of research in obesity, because we all know about metabolic syndrome, we all know about fatty liver, PCOS. Now people are heading more towards bone because this can have a huge implications. So what I try to do is to see whether these two inert organs, or what we consider to be inert in the form of adipocyte and bone, do they interact with each other, and what is really the implication of that. So there are three questions that I like to answer. First, is there a link between the fat and bone? What is the basis of the link, if there is a link? And finally, how should we go forward in that direction in terms of research and public health perspective? So now, there is now a clear-cut data which shows, as I showed earlier, that obesity is increasing, fracture rate is increasing. But is obesity associated with fractures? This is a big study which is looking actually at lower limb extremity fractures. And what you see, there is a 25% higher risk of having fractures in obese individuals compared to their non-obese counterpart. And what you see is a dose response. So if you are underweight, you are going to have less fractures. As you become overweight, odds ratio is 1.1, moderately obese 1.2, extremely obese 1.4. So if somebody is extremely obese, there is a 45% increased risk of having fractures. Now, how does it translate? If you have a doubling of obesity, let's say from 10% to 20% in India, there will be 1.6 million new fractures every year. So it's a huge impact what we're talking about. It's not just a simple thing in this regard. So increased BMI is associated with increased odds of fractures. Mind you, this is mainly about lower limb extremity fractures. Upper limb are even more common, which I have not shown here. Second part is very interesting, that obese children not only have more extremely fractures, but they are also more likely to die from traumatic injuries. So there are some mechanisms which cause their deaths more often, and this is something which we need to be very careful about. They're 60% times more likely to die. So mortality is 2.8 versus 4.2 with the same amount of injury. So this may be because of they have the metabolic abnormalities or whatever thing. So obesity is associated with more fractures, more death because of injuries. So this is something which we need to be really careful about. Now, is there a link between obesity and fractures? So what could be the possible causes of increased fracture in obesity?
Because of reduced bone mass.
Second?
Because of increased weight on the bone.
So load is more?
Load is more.
Third? They fall more because of the body structure and all. So these were the three things that people used to always say, okay, they have more fractures because they fall more. Because they have more load. So the amount of strain that you put on the bone when you fall will be more if your weight is more. But the question is, body should adapt to that. So definitely, even if the bone mass is not compromised, it is maladapted. So the adaptation level which is required to counter that fat bone is there. So ultimately, there is a low bone strength. And this is something which we'll look into further. Now, what are the issues when you assess bone density in an obese individual, which may be a confounding factor?
I measure areal bone density and not a volumetric. So, in an obese patient, it may falsely show a higher obesity, not bone density.
Yeah, so that will be one. So, if you look at DEXA, you will actually find that the bone density is falsely high. You can correct it for size, and that will be something which is good. So what we were doing over the last 3-4 years was to look at a lot of factors of body fat across school children. So we had this big study of 5,000 children in which we used bioimpedance as a marker. Now bioimpedance is something which also provides an idea of bone mass, but we were not very sure how validated it was. So there was a very good study which was done by Dr. Vaman's group from Pune, who used the same BIA machine and the same DEXA machine that we use, and they showed that BIA and DEXA are not interchangeable, but they do have a good indication in terms of where we are going. So if you're talking about a large sample of 5,000, for us it is impossible to do a DEXA scan because of logistics as well as ethical issues. So BIA comes up, maybe it's a poor cousin, but it gives an idea about how the bones are going. And we had some very interesting data. When we looked at a univariate correlation or a bivariate correlation, just factoring bone mass, we found that fat mass was a positive correlation. Now this is something which is expected. But when we corrected it for size, the fat became a negative predictor. So fat is a negative influencer as far as bone mass is concerned. So having more fat is bad. What is even more interesting is that when we did a linear regression, fat was the only parameter which was associated with a negative outcome in terms of body mass and bone mass, and this is something which we need to be careful about. So having more fat is bad according to our school data. Now the other important thing to look at, as the categories increased from underweight to normal weight, we had an improvement in the bone mineral content to lean mass ratio, which was not hugely significant, but it indicated that as you go from undernutrition to normal nutrition, your bone health becomes better. After that, once you become overweight, the bone becomes less. So there is an optimum range as far as the BMI is concerned. And once you become obese, it becomes worse. So what is this sort of epidemiological relationship known as? Riddhi, how do you describe this relationship? What shape do you think this is looking? Not really U-shaped, it looks like a J shape, inverted J. So if you talk about mortality and BMI, so BMI criteria are made based upon mortality. Underweight have more mortality than normal weight, overweight have more, and obese have more. So that looks like a total J. Here you have gone the other way. So if we had done the opposite, 1 upon the lean mass upon bone mass, we would have got that sort of a relationship. So there is a inverted J relationship between bone mass as well as, because mortality was a negative outcome, this is a positive outcome. So you have the inverted J basically. If you look at the positive outcome lean mass, you will again have that J relationship. So what it is telling us is that having some amount of weight is important to make your bones, but if you become too much, your bones become weak. Next issue was that similar study, and this is a very good study which was done by the NIH group, and they actually had access as part of their NHA and ES data of around 8,000 DEXA scans. So they did DEXA scans in children, and what they found was that as the percentage body fat increased, if you correct it for size, for gender, for age and everything, your bone comes down. And this is more for boys as for girls. Why? Girls have more fat anyway, so for them this 40% will actually be normal, and you start after that you will start having problems. Boys will be 30%, so this gap is of course expected. They also showed very nicely that in non-weight bearing areas you had a worse bone, while if you talk about a weight bearing area, the bones were normal. So what it means is that if you put a lot of pressure in your lower limb, your bones will be able to adapt to it. But hand, you are not putting any pressure, so that's why they are weak. So if you fall on your hands, you are more likely to have a fracture. So that is why obese children have a more upper limb fractures as compared to the lower limb fractures. And so they found these regional, gender and age differences which we discussed. But this is a very important thing, that fat is negative for bone. Now this is one study which Dr. Vaman's group did in Pune, and what they showed was that there was a, if we do not correct for size, BMD is more in obese, But when you correct it for size, it is less in obese children, which is again going with the same hypothesis as bone is bad. Based upon this, we evaluated our own data of around 213 individuals who actually underwent a DEXA. So these were obese children whom DEXA was done, and then we found which were the factors which were negative determinants of bone health, and again fat mass was the one which emerged as a negative predictor. So clearly, even if you become obese, your fat still has a bad effect on bones, and this is something which we found in this situation. Now, we have now shown clearly that there is a link between adipocyte and bone. Now, what is the basis of this link? So, Sajini, what could be the possible things you can think of how fat can be bad for bones?
More fat will various hormones.
So, you can change the hormones, you can environment can be changed. So, you can have an environmental effect, your adipokines can come in, a mechanical effect can all be there. So, all these factors are there. Now, Riddhi, what determines the bone mass? What is the most important determinant of bone mass?
Muscle strength.
No. What is the most important determinant of height?
Size of the bone.
Genetics. 80% of your bone mass is determined by genetics, and you are supposed to track according to that. Now, this 20% can change, and this 20% is all about physical activity, exercise, nutrition, obesity, calcium intake, vitamin D, all those things. So, genetics is most important, but then genetics you can't change. So, we are talking about what are the modifiable factors. So, there can be 4 reasons how fat can affect the bone. Of course, mechanical. We can think of environmental changes. We can think of the effect of adipokines, and finally the hormonal changes which happen with obesity. A lot of these are interlinked. So you can't say that hormones are not linked to leptin. Leptin will be linked. So these are all linked, but these are the 4 major areas. So let's go one by one. Now, if I talk about lean mass and fat mass, what is a more important determinant of bone?
Lean mass.
Lean mass. And lean mass is an indirect marker of strain. So when you do more exercise, you do more strain, your lean mass increases. When you do strain, the osteocyte feels that we are in a threat. Our bones will become weak, let's work more. Osteocyte signals the osteoblast. And it says, okay, make more bone through what? Sclerostin. So sclerostin is basically there which will be released, and sclerostin will basically inhibit, but if you are having strain, that sclerostin is inhibited and the bone formation happens. So if you have got more lean mass, bone formation will happen, and this is something which is shown, but still, fat is a major determinant if you still talk about in terms of bone mass. So fat is important. Now, how do these interact? And we talked about tracking of bone, and this is a very good study in which they followed up these children in terms of how their bones were growing over time. And they found most who were 3rd percentile remain 3rd percentile, who were on the top, they remain top. So most children track their percentile as happens with height. But there were 2 important factors. If somebody gained more lean mass, they had got more bone which was there. If you gained more fat mass, your basically bone became weak. So there is a tug of war between fat and bone. In a way, your bone is supposed to increase as far as tracking, but if you have got more fat, it will pull it down. If you have got more muscle, it will take it up. So exercise is a major determinant of long-term bone health. We talked about fracture rate, but we also need to understand is that there may also be an issue if you are having tracking issues. In a way, your bones will become weak forever, because your peak bone mass comes around 20-22 years of age. If that is less, you will have a long-term effect. So childhood obesity has an effect now of increasing fracture, but also a long-term effect in terms of bone density. So this is very, very important, which has not been studied yet, which will happen later on. Now this is very interesting. Now we know fat is bad, but is all fat bad? If you look at this data, there seems to be a time in which fat is good, and then it tends to have a relationship there. If you look at our own data, what we see is that there seems to be a normal bone till a level, and then there seems to be a threshold after which the bone becomes weak. So if your fat is up to this, you're okay. If your fat becomes above this, your bone becomes weak. And this is same as to what happens with, let's say, metabolic syndrome, any other abnormality. So what does it mean? If you have got more subcutaneous fat, you are okay. But if it goes into your abdomen, it is bad. So abdominal obesity has a bad effect on bone mass, and this is something which has been shown that truncal fat, basically they looked at the android android-gynoid ratio, and they found that it has a negative impact on the bone mineral content. And most studies, if you look at it, are DEXA based, who are looking at DMC. There were one study based on PQCT, which people are looking more now, but still DEXA is also giving us good amount of information that this abdominal fat is bad. Now, if abdominal fat is bad, we expect that somebody who has got a non-alcoholic steatohepatitis, which is a clear-cut marker, clinical marker of abdominal fat, will have a bad bones. And this is something came up from our own study, which showed that individuals with steatohepatitis had worse bone than those obese children who are healthy. So just having NAFLD in obesity causes your bones to be worse. So even if you have got same amount of fat, same amount of BMI, if you have steatohepatitis, your bones are bad. So fat distribution also plays an important role in that regard. Now, the next issue in this is further collaboration, which shows that if you correlate hepatic fat content and bone, it is also correlating very well. So not only abdominal fat, but also hepatic fat has a bad effect on bones. Finally, we talked about the interaction between the lean and the fat mass. If you've got too much fat, it goes into the abdomen. It may also go to the muscle. If it goes to the muscle, theoretically, you're weakening the muscle. So if you've got more skeletal fat, you also show that bones are weak. So they are very well assessed during MRS, and what they found that if you have more skeletal muscle fat, it is bad as far as bones are concerned. So fat above a level, fat in the abdomen, fat in the muscle, fat in the liver, and there is a study of fat in the bone marrow. These are bad for individuals. Now, how do you think, Riddhi, that fat in bone marrow is associated with bad bones? Where does this fat come from? Where do the adipocytes come from?
They come from mesenchymal stem cells. So mesenchymal stem cells differentiate into adipocyte, osteocyte.
Yes. So the same cell converts into chondrocyte producing cartilage, into myocyte producing muscle, to adipocyte producing the fat cell, osteocyte to produce osteoblast. So if there is a shift between conversion to osteoblast to the fat cells, of course your bone will have more fat and it will have less bone or osteoblast. This has been shown in conditions like thiazolidinedione. So TZDs cause a shift from, that's why they cause osteoporosis. They were causing adipogenesis. So people thought it's good if you have got more fat, you will reduce your insulin sensitivity because you will get more space in the subcutaneous tissue to work at. But in the bone, they converted these osteoblasts into adipocytes. So you had weak bones. So this is an important mechanism. So if you have a shift towards the osteocyte to adipocyte, your bones will become weak. So having more fat, particularly in the abdomen, in the liver, in the muscle, in the bone marrow, is bad. Which fat is good for bones? Can you think of it? Subcutaneous, and even be more precise, is the brown adipose tissue. So brown adipose tissue is good for metabolism. If you've got more brown fat, you are more metabolically active and it improves bone. The only two areas maybe fat is good till a level is subcutaneous and the brown adipose tissue, which we can evaluate further. So now we come to our overall hypothesis as far as mechanical model is concerned. If you have got too much fat, it goes in your subcutaneous tissue. If you can store it, well and good. If you cannot store it, it goes to liver. From here, it goes to muscle. From there, it goes to bone. And all of this causes weak bone. So this could be a simple mechanical model, which we thought of. What about environment? If you are not healthy, you will have a bad bone. So this is something which also people are talking. And very interesting study. This shows the number of cardiometabolic risk factors and the DEXA as compared to the body fat. And this is about bone mass in girls. So what it shows us is that if you do not have a cardiometabolic risk factor, as indicated by these triangles, for the same level of body fat, your bone is more. You see this line, the top line, as you have one risk factor, it goes down, and you've got two risk factors, it goes further down. So just having more cardiometabolic risk factors, even you have got a same amount of, let's say, the body fat, your bones will be worse. So this is something which is very, very important and interesting, and adverse effect of what we can say unhealthy obesity. And this is something which we showed for NASH and other abnormalities also. Now, how does this link up? So we say you have got fat, but just having fat is not bad. If that fat is causing you metabolic abnormalities, your bones are bad. So this was a very interesting study which tried to see whether insulin resistance can link up between bone and fat. And what they found, and they use a very interesting model of what is known as pathway analysis. And in pathway analysis, what you try to see is to see the effect of confounders and how one thing affects the other. So when they did a univariate analysis, they showed that fat is bad for bone. But fat also causes worsening of HOMA-IR, which is insulin resistance, and that also has an adverse effect of bone. So which is the pathway? Is it a direct pathway or is it through the HOMA-IR? So what they show is that in a multivariate model, there is no direct relationship between fat and bone. It is only through HOMA-IR. So if I would say one word, insulin resistance is the most important link between fat and bone. So why do you have more abdominal fat causing a bone problem? Why do you have more metabolically unhealthy obesity causing more problem in bone? Is all through insulin resistance. If you've got more fat, more abdominal fat, more liver fat, you've got more insulin resistance, and that ultimately is causing the bone effect. So this will be a very important unifying thing. This means that maybe if you improve insulin resistance by doing exercise, physical activity, weight loss, or theoretically metformin could have a positive effect on bone. And this is something which is a big area which needs to be explored in this regard. Now, this is important. So once we've shown that insulin resistance is bad for your bones, this is logical. If you have pre-diabetes, you have got worse bones as compared to somebody who has got normal glucose tolerance for the same level of BMI, same level of fat, something which our paper also shows that having dysglycemia causes impaired bone strength as compared to healthy individuals. So we have to be very careful in these individuals for their bone mass now and later on. And maybe think of some sort of an intervention which may improve their bone mass. So when we talk about insulin resistance, we are not only talking about diabetes, about lipidemia, about polycystic ovary, fatty liver. Bone is something which we also have to think about now. Now, how does all this get mediated? If your inflammatory markers are high, and I think this is just the association. If you have got bad health, your inflammatory markers will be high, your bone will be weak. But this is not going to help you out in terms of management. Insulin you can change. These will change if your metabolic environment improves over time. Now, next issue which comes is how do the other roles, other part come into? We talked about mechanical, we talked about environment. Now, there is a possible role of adipokines. And what is adipokine? Sajili?
Other things that are hormones that are secreted by the fat, you can say.
Okay. So we always thought that fat and bone are inert organs. Now we know fat produces a lot of hormones, bone produces a lot of hormones. So we'll talk about, today we'll talk only about fat. We'll talk about bone. We discussed once about sclerostin and how that affects insulin resistance. Now this is a very important thing. While fat has a bad effect on bone, bone can also affect the fat by sclerostin and osteocalcin, which have got an impact on liver and fat. So this is very interesting. I'm not going to talk about that today. Today's topic is mainly about adipokines, and we know two adipokines are main, leptin and adiponectin. So leptin with obesity, it increases or decreases? Increases. So people initially know, and how does leptin act? No, what's the receptor? Leptin receptor is like what? Is like which group of receptors? Rithi? This will be discussed in so much detail. It's like growth hormone receptor. So leptin, initially when they used leptin and looked into experimental data, bones increased. So they thought, okay, more leptin, more bone. But then when they studied more, indeed, what they found that if you become obese, this positive effect of leptin goes into a negative. And this is very, very important. And how does this happen? Is that if you look at a mice model, low level of leptin will improve your bone. But if your leptin goes up, it starts acting through the hypothalamus, through the arcuate nucleus, and that stimulates the sympathetic pathway, and that sympathetic pathway causes metabolic issues as well as issues on bone. So the major effect of leptin in obesity is central through the arcuate nucleus and the sympathetic pathway. So now if I try to just summarize, and this is something about adiponectin, which is very debatable. People say that this is a very early study which show that adiponectin actually causes inhibition of bone formation. So adiponectin will be low in obesity. So in a way, obesity may be better for bones. But this is something which is not substantiated in children. So we'll focus mainly about leptin. And what has been shown that leptin has a direct effect on bone. If you have low dose, it will improve. But if you have got too much leptin, it will go into the arcuate nucleus in the brain, and from there it will stimulate the sympathetic pathway and it will cause decreased bone. So again, I'll come back to the same inverted J-shaped model, which is common in epidemiology. You need some amount of leptin for your bones to grow. If you've got too less leptin, so leptin deficiency, or let's say anorexia, all those things, bone will be slightly less. But if you have too much leptin, your bones will be worse. And this is exactly what we talked about our BMI cutoff. So this is a very interesting thing to really understand. Adiponectin is theoretically going to cause inhibition of bone, but not probably very important. So insulin and leptin. And probably this leptin is driving this insulin resistance for all we know, because ultimately insulin resistance is an effect of fat. And this effect may be mediated through leptin. So I would say leptin is going to be a very, very important role which plays. And this I've been thinking for the last 10 years, but probably it's difficult to make, is that if you have leptin sensitizers, they will help in huge amount of things, because a lot of these obesity problems are working through leptin. And there is leptin resistance. So if you are able to overcome this leptin resistance, a lot of these problems like fatty liver, type 2, bone, PCOS will improve. So metformin is actually working a step down. So basically, if you've got leptin resistance, that causes insulin resistance. And you're trying to work at that. If you actually work at leptin, you may be much better. So people initially thought that if there's leptin deficiency in obesity, you give leptin, they will improve. And those who have leptin deficiency improve. The problem, however, is that most are not leptin deficient. It's leptin resistance. So the need of the hour is leptin sensitizers, which will really improve the outcome. This is something which is a theoretical thing, but that is a very important thing of the pathway. So now we've talked a lot about adipokine, environment, and mechanical, a word about hormones. And this may all come through leptin again. So high leptin we talked about, but how does hormones play a role in bone overall homeostasis? So we all talk about the trivariate of the osteocyte, which are the regulators, osteoblasts, which are the formations, and osteoclasts, which are the destroyers. So I would say they are like Brahma, Vishnu, and Mahesh. So they are trying to create, sustain, and destroy. So they are all working together to model the bone, to remodel the bone, and this is how they work. So now, growth hormone has got a positive effect directly on the osteoblast as well as via IGF-1. The negative effect, calcitriol has a positive effect, but very interesting. What does calcitriol do to osteoblast, Sajidi? If it inhibits, then it will be negative, so it improves. But when you have deficiency of vitamin D, it acts on the osteoclast to stimulate it also. So in a sufficient state, it will have a positive effect on bone. In deficient state, it will get calcium out. So overall, it's a positive. Cortisol will inhibit osteoblast through the RUNX pathway and the OPG mechanism, and it will stimulate the osteoclast through the RANK ligand pathway. And this has a negative effect. We all know about that. Testosterone, estrogen, DHT, they all have a positive effect on bone. Mainly estrogen is an anti-resorptive agent. And insulin has, of course, a direct effect on bone, but if you have insulin resistance, that will be bad. So we've got these four hormones which are positive, this hormone is negative. Now what happens in obesity? So if you've got more leptin, your growth hormone will be less. And we say that in adults, you need to have a lower cutoff of growth hormone, lower level of growth hormone in terms of the levels from leptin. If you have got adipocyte and fat in the liver, you will have insulin resistance. So this will be a bad part, decreasing insulin activity. You will have more aromatase producing estrogen. You will have more 11 beta HSG in the fat, which will produce more cortisol. You will have more 17 beta HSG. So in females, you will have more testosterone. So there's a whole hormonal imbalance. So these things will happen. So now if you see what happens because of adipocytes on hormones and what those hormones will do to the bone. So let's go one by one. So first thing is growth hormone. So Riddhi, what happens to growth hormone?
Growth hormone increases during obesity. Sorry, but growth hormone level is decreased. But
growth hormone level is decreased. That's what we're talking about. So your bones will be low. So if you have got more obesity, growth hormone will be less. And studies have shown that low growth hormone is associated with fatty liver. So again, fatty liver is the same insulin resistance. So it will have a bad effect on bone. What will happen to calcitriol? Sanjeevi? Why?
Because no sufficient amount of.
So I will not show on that thing on the fat. What is there in the fat for vitamin D? 24, 25. So adipocytes cause inactivation of vitamin D as well. So your calcitriol will be low. That's why we say you give double RDA for obese individuals. So that will be having a bad effect on bone. What will happen to cortisol?
Cortisol will increase. That's why bone is low.
Yes. So cortisol will be high, bone will be less. What will happen to insulin? Action will be less. So insulin resistance will be there. Estradiol will have a positive effect, but these things will club together. So basically, there are a lot of negative influence and possibly estradiol which we have to look at. So now we have talked about the basis that there is a connect, why there is a connect, what hormones role play, and now how the way for future. So in this regards, the key thing is that if you've got more fat, your bones are worse, and in India you will have 15 lakh more fractures every year if you double your obesity from 10% to 20%, which is a huge number. And because tracking will go, your bones will become weak for life. So this is something which we need to be very, very careful about. Now, how do we go forward? And I think most important thing is weight loss, and weight loss with physical activity. We talk about diet, nutrition and everything, that is important, but if you increase your lean mass and decrease your fat mass, that is most important. And then this will take care of your environment and your obesity. Calcium, vitamin D should be given, but don't expect that to cause an improvement in bone density. It's mainly lean mass. You have to build up your lean mass. And this is something which is very interesting data which showed that the amount of sedentary time and the amount of physical activity are the major determinants of your bone mass. And this is something we should also look at in our own children, how much time they're actually, and do something in an objective manner, how much sedentary time they have, how much play time they have. This is something which will make a determinant in that. Now, the other issue is a lot of people say if you lose a lot of weight, your bones will become weak. Children should not lose weight because bones become weak. This is not true. If you have a moderate loss in BMI, we anyway don't talk about huge amount of loss. We say 5 to 10% reduction in BMI SDS. That is not going to be bad for bone. And if you basically have your lean mass in control, it increases your better. So in the long term, you can lose weight mainly through lean mass, and that will help. So I think at the end we can say that poor bone health is an important determinant as far as the outcome is concerned, and we need to be careful about that in this perspective. So I think